Hello and welcome to Community Matters, a podcast from the Canadian Association of Community Health Centres. I'm your host, Hilary Leblanc. In this episode of the podcast, we continue to explore the impact of the COVID-19 pandemic and how the community health centres have stepped up in response. I visit with the staff of Blackberry Community Health Centre in Toronto to learn how their CHC has adapted to meet the care and support needs of some of the city's most impacted residents, including rollout of vaccines. Black Creek Community Health Centre provides a wide range of health and social services geared to the diverse needs of individuals, families, and groups living in the northwest regions of the Toronto. Black Creek CHC envisions a healthy, resilient, and empowered community where people are connected and support each other. Today, I am speaking with Cheryl Prescott, Executive Director of the CHC, and Michelle Weston, Senior Analyst, Planning, Quality, and Risk. Thank you both for being here today.
Thanks, Hilary. Great to be here.
Thanks, Hilary.
I wanted to start off first with Cheryl. If you could tell me a little bit about the Black Creek Community Health Centre, some of the main aspects of your organization, the communities you serve, and the services and programs you provide.
Okay, wonderful. So really happy to be here to share the story of our CHC here that's located in the northwest corner of Toronto. So we were incorporated in 1989 as a non-for-profit, and like other CHCs in Canada, we're governed by a community board, members of whom live and work within our geographic catchment. Through our board and our local service partners and our service recipients, our clients, we have a very strong and deep connection to our community. We have various service locations where our offerings include a suite of multidisciplinary primary healthcare services, such as the prevention and treatment of common illnesses and chronic diseases, such as diabetes and COPD. We offer referrals to and coordination, as well as navigation with other levels of care, such as with our hospital and specialists. We offer a variety of mental health and addiction services, health promotion services, child and maternal health services, among others. And all of these are delivered in a coordinated and integrated way. We also having a deep understanding of how the social determinants of health impacts overall health. We work with multiple partners in our community to address these determinants of health by connecting our clients and our community members to services in other sectors, such as housing, legal services, youth services, food issues services to address food insecurity, as well as education. And Michelle will go into a little bit more about the specifics of the demographics of the community we serve, but it's really important to note that the population that we do serve is one of the most diverse in the city and perhaps in Canada. And many of these individuals face significant barriers due to their income status, their ethnic origin, immigration status, or other factors. So in addition to our direct service provision, much of our work is centered on community development as well, specifically advocating and building community capacity to address the structural and systemic barriers that tend to lead to marginalization of these population groups. So we do a lot of work on anti-poverty, anti-racism, because these are issues we feel very passionately about, and we know that they're issues that significantly impact health outcomes within these population groups. So I'll turn it over to Michelle to talk a little bit more about the specific population within our catchment area.
Thanks, Cheryl. So as Cheryl mentioned, we're located in the northwest part of Toronto. Our community stands out in a number of different ways. As many community health centers, we really focus on serving populations that are facing both systemic as well as other barriers when it comes to accessing healthcare. Our community stands out in many ways as compared to the rest of the city of Toronto. So for instance, it's been shown that, folks who are living in the Black Creek Humber community face lower income rates. We often have folks that are newcomers to this population, people who are facing language barriers, We're serving a very ethnically, culturally, and linguistically diverse community. So we have many people in our community that are predominantly from the Black, African, Caribbean culture, Latin, Hispanic, South Asian, Southeast Asian. And really, these are folks that, again, we know are dealing with higher rates of chronic health conditions as well, unemployment, housing, and so forth. I would say also in Northwest Toronto, we do have a large number of non-insured folks. CHCs are really the only organizations where people who do have non-status are able to get, healthcare services. So we do have a lot of folks who are non-insured, people living without OHIP, and they face particular barriers when it comes to accessing care, and then ultimately, may have poorer health outcomes as well.
Well, the work that you're doing sounds amazing. I want to jump into your work around the rollout of vaccines in a moment. But first, I'd like you guys to take me back to the start of the pandemic and walk me and the listeners through the impact that you've seen on the people in the community that you serve and how your CHC has adapted and worked to meet the local needs of everybody over the past 18 months.
Okay, so I'll take this one. So I'd like to start by saying that much of the work in CHCs in our local communities is evidence-informed and evidence-based, which means we start from a place of knowing what may or may not work with individuals or the groups in the community. So this includes being very deliberate in ensuring representation amongst our staff, as well as continuous learning about the populations we serve. And this has been very effective in addressing the pandemic as it's running its course. So at the start of the pandemic in March 2020, knowing what we know of the population in this community, the barriers faced by those that are non-insured, as Michelle mentioned, that are essential workers, those living in crowded spaces, often with multi-generational family members, with language barriers or linguistic literacy level barriers, not to mention the high prevalence of chronic conditions within the community, all factors which we feared would lead to an increased risk of contracting the virus, becoming very sick with the virus, as well as being hospitalized for members of the community we serve. And this was all confirmed by early data that we read and heard about in the US and in the UK, who began to collect socio-demographic data around COVID. And the picture that emerged was really stark. It showed the disproportionate impact of COVID-19 on the poor and on the racialized, specifically on the Black and the Latin Hispanic communities. So again, folks, the populations that were very in high numbers in the community served by Black Creek. So we were not surprised when early epidemiologic data from the City of Toronto showed the high positivity rates in the area that we serve, in the northwest area of Toronto, and other areas with similar demographics across the city. The disproportionate positivity rates among racialized groups and those living in low income circumstances was very real. So what did we do as a result? I think one of the first actions that we took, especially among the leadership of Black Creek, was, along with other Black leaders in our sector, we advocated for the collection of socio-demographic data, including race-based data among COVID cases that were emerging in the city. And I think at this point, I'd like to also speak a little bit about the fact that we can't speak about the COVID pandemic without mentioning the rise in awareness and and how things like racism and discrimination came to light with the pandemic. The first was the anti-Asian sentiments and discrimination against this group due to the messaging about where the virus originated. The second was the rise in awareness of anti-Black racism when the world that was so much more connected through media became aware of the George Floyd murder in the US. And more recently, the third thing I would sort of highlight is the discovery of the graves of Indigenous children across our country. So in addition to the COVID-related illnesses and loss of lives, we cannot underestimate the ongoing pain and suffering of those dealing with historical racial trauma. And as CHCs, this is again part of our work. This work is embedded in the services that we deliver. So for communities like ours, with a large number of Black individuals, we were doubly impacted by these factors, and we continued to, we spoke up. We were not silent, and we advocated within our system leaders to acknowledge the barriers faced by these groups that continuously struggle for equitable, fair, and culturally safe access to services, not only in the community, but across other parts of our system. And this work continues, and I'm hoping it will continue post-pandemic. And I'm pleased to see some of the strides that are being made across our system through Ontario Health, provincially with a new equity framework. Ontario Health, the Toronto region, put together an anti-Black and anti-Indigenous racism working group that developed several pillars to address these issues, as well as the Alliance for Healthier Communities that recently refreshed their health equity charter, because health equity is just, again, the core of our work. So all of our actions from the beginning of the pandemic really was through this equity lens. So specifically, we worked with our agency partners to address some of the immediate impacts of COVID-19, such as, you know, sort of supporting folks with income security. So for example, many folks did not know how to complete the forms for the access to the CERB benefits. People needed help with groceries and meals and household items. You know, so again, working collaboratively with some of our community partners, we were able to expand our partnerships. We were able to form new partnerships with culturally, I would say, appropriate services and food providers. So for example, with the African Food Basket, who we were able to support families with the delivery of fresh fruits and vegetables that were part of their culture. So and we were able to do this through early funding, one-time funding from all levels of government, through the city, the province, the federal government, United Way, and other foundations. So again, just really making sure that we met the needs, immediate needs, day-to-day needs of people who might have lost jobs, who were already living in, as I said, low-income situations. The other thing we did was advocated for accessible testing sites in the community, in places where it was easy to access by walking. So in apartment buildings, in churches, in the neighborhood, there were walk-in sites, so there was no need for making an appointment, which was a barrier to many folks in the community. And again, at that time, we also had to work with community members. So we recruited community ambassadors or community champions on the ground who were able to help us outreach to folks in the community, because at the time, many community members did not believe COVID was real. There was lots of misinformation that continues, and I'm sure you'll hear a lot more about that with when we talk about the vaccines. So we had to really put lots of boots on the ground. It wasn't just our core staff, because our core staff were also ensuring that our core services were being delivered, because people still needed diabetes care, people still needed counseling, people still needed primary care through their physicians and nurse practitioners. So much of the work, we really reached out into the community and worked with the community to help us to reach those that were most harder to reach. And we continue to use this model as we work through the vaccination efforts, and you'll hear more about that as well later. I think that's it for now.
No, that was a perfect segue into my next question, which is, of course, about vaccine rollout. It seems from the start of the pandemic, there was emphasis on access to vaccines as the critical milestone throughout the pandemic, where we were really going to be able to start turning the corner into a safer space throughout the pandemic. Michelle, what were your hopes and concerns around how vaccine rollout would work, knowing the clients and the community that you serve?
Yeah, absolutely. I think as Cheryl mentioned, when COVID first hit, there was a lot of mapping that was done across the city of Toronto, and we could see quite clearly that our our communities were being disproportionately hit by COVID. So we were already in a situation where we were standing out in the data when it comes to high COVID rates. As vaccines started rolling out, we began looking at vaccination rates across the city. And once again, Northwest Toronto and the Black Creek Humber area was standing out again. So not only were we dealing with, the highest rates of COVID in the city, we were also dealing with, at one point in the beginning of the vaccine rollout, literally the lowest vaccine rates across the city. And again, not at all surprising, given what we know about the community, knowing the stigma that this community was already facing when it comes to, dealing with COVID and getting tested and being essentially stigmatized as a hot zone, knowing the barriers that our community was facing. So I think one of the concerns that we had from the beginning was just ensuring that there was a real health equity lens when it came to the rollout of vaccines. So not so much about having, vaccines available, blanket in volumes across the city, but ensuring that the communities that really needed it the most and the populations that really needed the most were getting equitable access to vaccines. And in some case, we know in the beginning there was a huge issue with vaccine supply. There was a shortage. We were hearing about people, lining up for hours and hours for vaccines in communities, and yet, our community was facing, a lack of vaccine, and also lack of spaces and lack of ways in which people can access the vaccines. So, looking at, how do we, distribute vaccines equitably in community? How do we ensure that community is engaged in the process of a vaccine rollout? Ensuring that, we are, listening to community when it comes to where vaccines should be placed, who we should involve, how do people want to get information? Those were all of the things that we wanted to make sure were part of the planning process. I think that, the vaccine implementation really was an opportunity for CHCs to take a leadership role. I think Black Creek and other CHCs in the city really were poised quite well. CHCs have the trusted relationship within the community. We have the extensive partnerships across the sectors within our communities. We have that experience working with a social determinants of health approach and working from that holistic manner, really, again, taking that equity lens. And really having that opportunity to, work with folks that are living in the community themselves to really speak to their experience and have their experience really drive a community-led response. So I think it was, one of the things that we wanted to make sure was that we were working with our partners, working with our community ambassadors to ensure that our communities and those specific neighborhoods and those specific populations that needed vaccines were the ones, receiving it first. We had an opportunity to work through the Toronto Sprint strategy to actually, plan and coordinate and lead the coordination of mobile vaccine clinics in Northwest Toronto. And that was such an important step, the CHC being sort of the face of a mobile vaccination strategy. And it really put us in a position where we could really have that community-led, community-driven, data-informed approach when it came to rolling out vaccines in our community. And ultimately, it resulted in, we had a huge increase in vaccination rates within the first month of doing mobile clinics. We were able to engage and do clinics in places that people felt safe and comfortable and accessible in. So doing vaccine clinics door to door in apartment buildings, in Toronto community housing buildings, and really getting vaccines to where people needed the most. Doing vaccines in churches and mosques, working in schools and really working across all sectors and all partners, ensuring that, vaccines were getting to the people that needed it the most. And as Cheryl mentioned about the collecting data, collecting that social demographic data. So at our clinics, we were collecting that race-based data. We were collecting information about the race, language, ethnicity. So not only were we, planning vaccines from an equity lens, but really, I think setting the stage for using that data in order to, decrease barriers to access, reduce inequities and hopefully improve health outcomes in the long run for those populations.
That's amazing. I've even recently had heard in other news places talking about how Black people seem to be the most hesitant. And I was asking those questions around, is it real hesitancy, or is it these barriers that people seem to be so unaware of exist, and how it's really amazing how much, you know, your community health center tried to overcome all of those barriers and really help your community.
I was going to say, and that's, I mean, that's exactly what we're talking about here. Like, once we saw the rates of vaccines go up as soon as we started doing mobile clinics, you know, that's where, you know, I think that really challenged this narrative that has been put on our community around vaccine hesitancy, and, you know, it being a COVID hotspot, and COVID being so linked to personal choice rather than, you know, looking at the systemic barriers. And we saw that this wasn't an issue of vaccine hesitancy, it was an issue of access. You know, and this is what happens when you bring vaccine into community. You know, we had thousands of people lining up for hours in the rain and the snow. You know, they weren't leaving. They were ready to get their vaccine. You just needed to bring it to them where they could get to it.
Exactly.
Yeah.
We're now 8 months into the vaccine rollout. Cheryl, what have your experiences been in terms of obstacles and successes within the communities and clients that you serve? And of course, if you could describe the role that Black Creek has played in terms of outreach, vaccine clinics, and other vaccine uptake efforts. Though you did do a great job in covering this a bit already.
I'm going to start with the successes, because I really think that we've seen tremendous successes, just in terms of even our I would say personal and professional growth, in how much we've actually learned about our community that we serve. And I think that is to everyone's benefit. It's a benefit to the organization as well as to the community, because we are now, I think, poised to deliver even more effective services to the community members. So because of that early engagement and that sustained engagement with community residents, community partners, as Michelle mentioned, you know, we now have our CHC in a way has overflowed into the community. We've been able to grow beyond our walls, if you will. I mean, while we have multiple sites, you know, the expectation sometimes is that people will come to us for services, but we've really been going to where people are at. We've been really meeting people where they're at in their journey along this pandemic. So I think, you know, we've just been able to expand our partnerships, especially diversity of partnerships. We've worked in our vaccine rollout, we've worked closely with the Vietnamese community, the Latin and Hispanic community, the Muslim community, and the Black community. So, you know, and we've taken from them, we've worked alongside them. It wasn't, you know, just Black Creek doing this work. It was working with these partners hand in hand. And I think these engagements really helped us to address those challenges of vaccine hesitancy and lack of confidence in not only the vaccine itself and worrying about, you know, this vaccine was developed too quickly, we're not really sure, you know, we trust it, but also the lack of trust in a system. So by working with our community partners, by really engaging with community members, I think we really we were able to have discussions, authentic discussions. I'll talk about our partnership with the Jamaican Canadian Association, for example, where we've done several vaccination clinics, and these clinics were planned so that people felt safe. We ensured that they, in partnership with the Black Physicians Association of Ontario, our vaccinators were Black. Our community ambassadors from the community were Black. So there was a presence of individuals who many of our community members don't often see as clinical providers, simply because there's not, I guess, a large number within our hospital systems and other healthcare delivery systems. So we were very deliberate in engaging with the Black community of both providers and community folks, community ambassadors, and created a safe space for the vaccinations. So people came out. I think through our efforts in total, we might have vaccinated over 5,000 individuals from the Black community. And, you know, we saw some of the social media posts, you know, where people said things like, I've never experienced this in my healthcare journey in Canada before. I had a Black vaccinator who, eased my fears, who I felt comfortable speaking to. I was able to, after I got vaccinated, I got a patty and soup. And, so what we did was created an environment that made it very comfortable for people. And I'm not saying that this is something that it's, that should be replicated everywhere, but we really took the cues from our community, and we worked with community partners that could really bring that representation and that reflection of the people that we serve. And similarly, we did it with the Latinx community, with the Vietnamese community. And I think it's that deliberate attempt to make people feel safe in their care through, providing them with the care providers, as well as individuals who really look like them at all levels of leadership, all the way through their the direct service that they're receiving. So, and that's something I hope that we can continue with across all areas of our care, not just in our COVID response. However, I do see that it may be a challenge. So I'll just talk a little bit about the challenge. I think, challenges are sustaining partnerships and engagement with community post-pandemic, maybe not as easy as we think, simply because of the way we're funded. We're funded by, for certain positions, and we are funded for certain targets, performance expectations. And I think there's just not there's not enough emphasis on the relationship building that needs to happen. We need more staff, core staff that's funded to really work on engagement and building relationships across all sectors of our care delivery, whether it's healthcare or social services, because they're so intertwined. So I hope that, I think to really overcome some of the challenges we see now within certain communities, we need, more sustained supports and resources to carry on some of the learnings that we've had throughout COVID. And I'll stop there and just turn it over to Michelle to add more.
Yeah. I think when we're looking at sort of the long-term impact of communities, COVID on communities, I think, I would definitely be wanting to look at, some of the opportunities for how policy affects our communities, right? So knowing that, like looking at COVID and seeing how many folks are essential workers, and how do we, look at things like basic income, to help provide them, with something more sustainable in the long run. We know that people were not able to take time off work because of COVID. So these are folks that are living without, sick benefits, basic things that would basically allow them to stay home and be safe. We saw a lot of the emergency supports that were, the government was able to put in place, like CERB and other financial support. So we know that those things are possible, and we saw that those made a real difference in the lives of the communities that we were supporting during that time. So, looking at, in the long term and what can help support our communities, like there needs to be, supports from the government that address the systemic barriers that are leading to these health inequities in the first place. And that'll go a long way in helping to improve the health of everyone.
It really stuck with me, Cheryl, what you said as well about, the representation and how important that is to make people feel safe. And I was just thinking that I've never, if anyone's listening who cannot see me, I am a woman of color. I've never been treated by a Black person, Black physician, had a vaccine given to me by a Black person. So I can't imagine how important that must be to someone who is, questioning the legitimacy of it all and so afraid of how all of this is panning out. So that's such a crucial thing that I think a lot of people might overlook. I'll ask you both this final question. What do you both think that the experiences over the last 18 months say about the ability of Black Creek Community Health Center to adapt to emerging social and political health issues and the importance of CHCs within our health and social service systems? Michelle, if you want to go first.
Yeah, I mean, I think, as we've mentioned, this has been such a time of learning and growth for our organization. I think we've had to really hit the ground running and be very, very adaptive and flexible and meet the needs of community. I think what's great about CHCs is that we are so embedded in community. This is a model that truly is poised to provide that wraparound, holistic approach to people who need those supports the most, and really, really working from a social determinants of health approach. I think COVID was something that just, really showed, what can happen from a social determinants of health perspective for people. People were being affected across the board, financially, social wise, social inclusion, their ability to, obviously be healthy and maintain good health. And I think CHCs are really, that's really their wheelhouse, is to work from that approach and really have that community-led, community-based perspective. Again, I think, looking at the communities that we serve, each CHC is unique in the way they develop their programs and needs, but I think we're very well poised to continue to meet the evolving needs of our community, because we are so responsive and we are very much community-led and community-driven.
Cheryl?
So what I will add to what Michelle has already said is, I think the words that stick in my mind are just our nimbleness and our flexibility. And I think Michelle touched on this as well. It's just our ability to be able to pivot very quickly, because we do know and we're closely aligned and engaged with our communities. So for COVID, we were able to continue our core services. We were able to continue primary care, but at the same time, we were able to add on and pivot in a way to meet the real needs that were emerging and that we didn't know about. But we had good guesses because we are so in tune with the community. So I think, this is such an important thing for community-based organizations, and an important role for us as CHCs, because we saw the devastation and the burden on our hospital system, because our hospital systems were ready for COVID cases. However, what would it look like if we were more, there were more of us around, and we were able to really stem that tide and keep people well, and they were able to live a little more healthful in their homes and in the community, because again, that's who we are. We are in the business of keeping people well and helping them to manage their conditions at home, and not having that burden on our emergency rooms and decreasing stays in hospitals. So it just makes so much good sense for both individual health, community health, as well as economic sense, really, for community health centers to be that place, that go-to to respond to not only emergent needs like a pandemic, but just overall health needs. And I think other than that, I think what the other piece that struck me throughout the last 18 months too is just that importance of community governance. I know that our board was very engaged throughout the pandemic, despite the sort of having to shift to virtual meetings, but they were involved in critical decisions around the impact of the pandemic on the community we served. And because they knew the community and they saw that disproportionate impact, they wrote letters, I guess, to our decision maker, politicians, around, for example, the disproportionate impact of the children who were children in low-income environments, and the impact of prolonged school closures and online learning on children in this community, because they understood that many of these children faced multiple barriers compared to those from more affluent neighborhoods. For example, in the affluent neighborhoods, parents probably had the luxury of working from home, had some help from others that they could pay for, they could hire tutors. But children in communities like this, where parents are dealing with having to work multiple jobs, they couldn't stay home from work. Parents were, again, living in low income situations. and could not support their children as well. So with all the devices and the stable internet. So I think, having board members being in tune with those issues, I really appreciate it. So I think this is our the essence of the CHC model is we're looking at the totality of those social determinants of health, the impact of, lack of good education on employment and et cetera, all of that impacting people's access to health care. So we can go on for a long time, but I know that, we have to finish.
Of course. Well, I mean, you encapsulated that perfectly, the business of making people better, a health business. It's so important. I want to thank you both, Cheryl and Michelle, for taking the time today to speak with me, and thank you both for the amazing work you're doing with Black Creek. If people wanted to find more information about Black Creek Community Health Center or in the work that you're doing, where would they go look?
For sure. They can check out our website, so www.bcchc.com. We're also on social media. We have our channels on Twitter, Instagram, and Facebook, so Black Creek CHC, and we also have a YouTube channel as well.
Perfect. Thank you both so much.
Great. Thank you.
You're welcome.
Thank you for listening to Community Matters, a podcast from the Canadian Association of Community Health Centres. To learn more about our association and the important work of community health centres across Canada, go to www.cachc.ca.